Good morning. I know we did kind of a quick, slight overview of where some people are from, but let me see a show of hands if you were not from Louisiana. All right, what if you're not from the Gulf Coast area? All right, well, happy fall, y'all. Today's the first day of fall. And it is only going to be 97 degrees. So we thank you for bringing some cooler weather. This is what we do. A little piece of advice from a lifelong Louisianian. When you go today to order your pumpkin spice latte, make it iced. Yes. I promise it's a world of difference. You don't want the pumpkin spice sweats. Welcome to our state. Welcome to New Orleans. I do want to start off with a special thank you to Diamond. I think I have raised her blood pressure just through the roof. I arrived about 5 minutes before we started because of traffic. But I was looking at the agenda, and I know what session you need to attend, and it's the smooth jazz and data one this afternoon. I think it'll kind of, take your blood pressure down a notch. I assume that one's going to have some jazz music playing at some point during the session. So, I am Karen Stubbs, and I am head of the department, within the Department of Health of the Office of Behavioral Health. But I really only have two skill sets, and one of them I've already failed on, and that was that I'm clicker today, and I'm looking at my clicker sitting on the table. So I have failed miserably in one of them. The second is that I can run in from the parking garage and run right on stage and start talking. So I've done that one. I've been pretty successful. But the brains behind our team and our success from the department's perspective are sitting here in the room. I would like my CSOC team to stand up, if you don't mind. I'm not going to introduce you because I don't want you to be embarrassed, but please just stand up so everyone can see you and ask you guys the questions afterwards. We are so excited. When we were asked to speak, I said, y'all have to come. Like, I'm going to get questions, and I'm going to need to use you guys as well. Syralja, I'm going to let you introduce yourself and your team, and then we'll start.
Sounds good. Well, Karen gave you a little bit of advice about pumpkin spice. Here's my advice about walking around. If somebody asked you, they bet they know where you got your shoes, do not fall for it. You will buy them a drink. Don't fall for it. Has anybody heard it already today? Yep, see? Yep, I knew it. Did you have to buy the drink? Because you're smart. I was not smart the first time I came here, and I had to buy somebody a drink. So, hi, I'm Syralja Griffin, excuse me, and I work for Magellan Healthcare. I've been at Magellan since we began in Louisiana 10 years ago, about 5 minutes before Karen came to the Office of Behavioral Health. And like Karen, my team is here. They're really smart people. So again, Karen suggested that they wear matching t-shirts, but we didn't make them do that because that would have been mean. But can my Magellan folks stand up? I'm so proud of y'all. All of you. Yeah, you too. All of you. Yeah. I say all the time that they make us look good because they are. They're smart and kind and dedicated people who want to take care of kids and families. So y'all make me proud, and really hard questions go to them later. Yeah, all right, it's your turn.
Okay. All right, so, again, failing on the clicker duties. Here we go. We've already introduced ourselves, Karen Stubbs and Syralja Griffin. We have been together for a very long time, and you'll see that come out in our presentation, and it might be one of the keys to the success between the Department of Health and Magellan because we have some pretty long-lasting staff. So a little bit, well, you guys can read this. We've got no financial relationships that will cause any conflict. All right, so our objectives today, there are 3 objectives, and they're pretty straightforward, and they kind of sort of align with the title of this presentation if you heard them introduced, which wasn't super creative, but was exactly what we're going to do today. We're going to talk about how and why we adopted the CANs way back in the day, kind of our outcome measurement tool for the coordinated system of care, which I'll introduce to you guys in a minute. We're going to talk about how we evaluate the ways in which the CANs has evolved And there has been a lot of evolution. There's been an evolution of our system, an evolution of the relationship, and definitely an evolution of the cans. And then we're going to talk about the newest applications of the cans and kind of now that people are used to cans, what they want to see done with it, and kind of the excitement and vision around the cans, beyond the original vision. All right. What is the coordinated system of care? I'm going to start for a second with giving you a little idea of Louisiana's landscape. So we are a Medicaid managed care state. We've got 5 managed care plans that do both behavioral health and physical health, so they're integrated. And we have Magellan as a managed care plan that does the coordinated system of care program, and I'll talk about that in a minute. We call coordinated system of care CSOC. It is actually now very hard for people to remember what CSOC means in Louisiana because everyone calls it CSOC. So you'll hear that throughout our presentation. It's the coordinated system of care. And the idea behind this began well over a decade. In fact, I had someone at a conference come up to me yesterday and said, it's been over 10 years. I thought, well, that's a random comment, just in passing, but it has been. It's been over a decade. Like literally, he passed me and said that. I was like, Daryl, okay. But we started talking about a better way to serve our children and youth, children especially in Louisiana's state systems. DCFS, Department of Children and Family, that's our child welfare. OJJ, Office of Juvenile Justice, it's our juvenile justice system. Even Department of Education was at the table. At the time, we operated with a really roughly related, loosely coordinated, really not at all, network of group homes and institutions that were really contracted by different state agencies. A lot of times the different state agencies all had a contract with one group home. All the contracts were different. I used to write some of them for OJJ. All the per diems were different. All the expectations were different. But in that home, you'd have OJJ and DCFS kids, but it was all over the place. There was really no standard criteria for admission. There weren't a lot of outcomes. If there were, they weren't standardized, at least between the different contracts and agencies. So it was really hard to do an apples to apples comparison that could be made, how and when kids returned home was really inconsistent. And so the governor's office at the time, along with the 4 child serving agencies, again, clicking, I'm forgetting to click. I'm on this slide now. Just such a failure in that second responsibility. Okay, I'll do better when it's your turn, Syralja.
Okay, good.
The 4 child serving agencies, and I keep saying 4 because it was interesting that we had Department of Education at the table. They still are, but I've heard around the country that that's a little unusual as well. We also had youth and advocates that helped guide in these decisions. And they started looking at a model, went to a couple of states to find something that was evidence-informed, had consistent criteria, cost-effective. At the time, we were in a really bad situation with our budget, and really had standard and accessible tools. These groups of people made up our CSOC governance board that still meets today. It's still active. We're a different governor now, but he issued another executive order mandating and continuing the governance board, and they're active and they meet and they go over data at every meeting. And this group reached out to Dr. Lyons and asked for help around the cans. And we'll get back to that in a few minutes. So again, the coordinated system of care, a few details about it so you know what we're talking about. This really is a wraparound model. It's our wraparound model for kids aged 5 to 20. They are most at risk of out-of-home placement. We used to say in or at risk of out-of-home placement. We do still have the ability for youth, for example, if they're transitioning out of an out-of-home placement, like our psychiatric residential treatment facility, there can be a little bit of overlap in order to have that transitional planning. But they're at risk of out-of-home placement. For those of you who love Medicaid and love federal regulations, and I know I can't be the only person in the room, we're operating under a 1915C home and community-based waiver. So that's been a really fun experience also. We can serve up to 2,900 kids statewide. And so we recently kind of increased our cap. We had COVID, which kind of stalled out a lot of our referrals, but we can get up to 2,900 kids, and it is statewide. It's everywhere. It is a network of a couple of specialty providers, our wraparound agencies, family support organizations, some specialty service that you get through the enrollment in that waiver, and then also, and a lot of people don't realize this, all of the other stuff that regular Medicaid gets. So a lot of people got confused. They thought when you switched over to the waiver, you lost maybe your kind of run-of-the-mill behavioral health services, but those are also still incorporated in with Magellan when you're in CSOC. All right, let me issue a warning here. You're about to see and hear a few things that might be confusing. They might make you a little uncomfortable. And if you need to step out of the room and compose yourself and come back in, we are here. We welcome you back. But we're going to talk about a dynamic that people aren't really familiar with in a managed care state contractual relationship. And it's called respect. With a little bit of friendship thrown in. As I mentioned, over a decade ago, we awarded Magellan, we had a request for proposals, Magellan responded. They were awarded in 2011. A lot of us have been here since then. At the time, Magellan had all Medicaid population in behavioral health plus CSOC. I mentioned an evolution. There has been an evolution. We've integrated our behavioral health services, but CSOC was such a vulnerable population. We kept it carved out, and we kept it with Magellan. And it's really made a world of difference in the evolution of the system. I often say back in 2012, I was pregnant with one of my children, and I'm not kidding, in the hospital after I gave birth, my husband and I joked, we named him John Michael. But we joked that he might actually respond to Magellan because he heard it so much in the womb, because we were not far into implementation, and Magellan was 24 hours a day for me in my house since I was over the contract and we were getting up and rolling. It was a lot of work. We came together excited. Yay, we've got managed care. We're gonna have this great CSOC program. We've got Magellan and they seem really cool and they've got a lot of experience around the country. And then we had one of those oh no moments when we thought, well, none of this exists now. We have to build this system. Magellan, you got 90 days to get your butts down here and find an office and set up and get your computers and hire all of your people. Oh, and none of these providers actually exist. The few that do have never billed insurance in their life. And there's a lot of other things that was in that RFP. Did you realize that you committed to doing that? And it was an experience. It was rocky, but they had to do things like collect baseline data. They had to train everyone on the cans. I mean, we hadn't had really anything like that in a large scale, especially for children, really in Louisiana. They had to find wraparound agencies, and a family support group didn't exist in Louisiana. The concept was even a little foreign. So we had to tell people what it was first and then decide who wanted to do it. We were building the plane while we were flying it. I mentioned Magellan had to actually move here and open for business and hire their staff, the Department of Health, the Office of Behavioral Health. So we also have an interesting relationship with the state Medicaid agency. We're both under the Department of Health. We are equals, and they granted us essentially full authority to operate behavioral health in the Medicaid system. The Behavioral Health Department was not well versed in contracts like this, value-based. I heard, Medicaid regulations, the code of federal regulations. I mean, I got there and ordered one. No one even knew what I was talking about. How to operate a Medicaid team. Candace isn't here, but she was one of my first hires. She's over our quality department. And she got in and she's like, all right, so managed care. And I said, yeah, we're going to figure it out together. And she literally bought the big yellow books. It was Managed Care for Dummies. You know, you've seen them like in high school and college, like whatever. Like there is a managed care book like that. And we were learning about it as we were building it. But then we improved and we grew and we grew and we grew and we grew. And now we're sitting here talking about our experience. Our partnership also evolved. There was trust and mistrust and trust and mistrust and arguments and rates. But through it all, I think there was a mutual respect. There were nights in the department where we literally had to go find lamps in people's offices and turn them on in the conference room because they turn the AC off at 5, which is horrible, but the lights go out. And we were in contract negotiations till late one night. So I don't know if that was, you weren't there yet.
No, it's not.
We had these experiences which really allowed some flexibility in our relationship. And so that was really great. And we improved and we grew. So a little bit more about why we're up here. And this is the part where I turn into clicker. And I'm going to hand off to Syralja.
Thank you, ma'am. Karen said we're building the plane as we fly it. At Magellan, we used to have a logo, and it was like an open door, and it said, getting better all the time. And isn't that a nice thought? But we another department got a complaint from a psychologist about something we did, and I'm sure they were completely wrong and we were completely right because we completely had it together. But they changed that logo very cleverly to making it up as we go along, which was kind of true. Like she said, we had 90 days. But like she said, we've come a long way since then, and I'm so grateful for the partnership. I'm so grateful that an attorney understands mental health and is invested in it and has been a really great advocate, not for Magellan, but for the kids and families in Louisiana. And it's just we're really fortunate to have that, because I don't know that everyone always does. So my job is to talk about the cans. So here in Louisiana, we adopted the adoption of the cans. There you go. You're rocking the clicker now. That's great. Excuse me. So like Karen said, we focus this program on a wraparound model. So if you want to think about it, it's a full behavioral health carve-out where wraparound is the center of everything. And the work of the wraparound teams begins with what happens with the cans. So in Louisiana, we use the cans for a few reasons. One, we use it for eligibility determination. We have these algorithms. It used to be on a bubble sheet, and I could just glance at a bubble sheet and pick the shape. Not quite so much anymore. I'm a little out of practice. But we use it for eligibility determination. We use it for service planning and for quality improvement initiatives and monitoring for outcomes and to inform larger systems. Excuse me. Okay, that was like just the introductory. Now I can talk. All right, so why in the world did we decide the cans was good? I mean, y'all know, everybody here believes the cans is a good tool, but I'm going to tell you why we believed it was a good tool. One, it's easy to learn, right? It's not always easy to pass the test on the first or the second. Just real quick, who passed the test the first time you ever took it? Show off? Seriously. You're show offs. I think I passed. Depends on the year. Depends on the year. This last year I did it on the first try, but I'll just say in the 10 times I've done it, thank you very much. In the 10 times I've done it, I've only done it on the first try, maybe twice, maybe. But we said the smart people are in front of us, so that's really helps. But we used it because it was a multi-purpose tool. Lots of folks could access it. People who are clinicians, non-clinicians. It's really accessible. But again, I'm telling you all that, which you already know. What's also nice is it kind of changes the language we use with families, where we make what's going on with them accessible and make it where anybody who takes the time to look at the tool can understand exactly what's happening with that young person and their family. We talk about the cans being a communometric tool, And the first time I heard that, I made a face, and I said, what in the world is that supposed to be? And I thought, that's got to be made up, right? Well, it was, but that's okay. But as I learned it, I realized that that's what's great about the cans, is that it really gives a diverse group of stakeholders, all kinds of people, language that they can use to talk about what's happening with kids and families without presuming the cause or making assumptions about who they are, how they got there. And that's a beautiful thing about it, that it took my skeptical mind just a little while to get it. And so also in Louisiana, we use the cans to determine eligibility. Like I said, there are algorithms, there are codes, there used to be bubble sheets, and now we just have magical computers that spit out answers for us. So it's been really nice to have. Also, we use it for service planning. So one of the requirements for our wraparound agencies is to use that CANS to help families figure out what are those needs that are important to you, what's going on with your family, where do you need to go, and what do you have going for you, what are your strengths to help you get there. And then lastly, we're able to use the data that we have to inform child serving systems. Karen mentioned the governance board, and the boards and commissions are not really a exciting kind of entities to have, but our governance board has been really nice because they ask questions that push us to be better, and it helps inform the work that they do, and it definitely helps inform the work that we do. Okay, you're trying to click and I'm trying to turn the page on my tablet, and I mean, we're both failing at technology, probably me more than you. I'll just click it anyway, and I'll make it up as I go along.
Early use of the cans.
Oh yeah, early use. You did click it. Okay. So like I said, early on, we focused on individual kids. We used it for eligibility. We used it for care planning. We measured individual kids' outcomes. I want to be real clear about that, individual. So I could tell you that Johnny had a 7-point decrease in his CAN score. Had that. Now, could I tell you what everybody in Johnny's neighborhood got? Couldn't tell you that. But we were able to tell you individually. Okay. All right, now let's talk about where we went with the cans. I'm just going to give up on my notebook and I'm just going to talk. There we go. So some of the early things that we did to use cans in new and different ways, for us anyway in Louisiana, one of the first things we did is we ended up having to change our eligibility algorithm a little bit. So because we were really fortunate to manage all of the Medicaid behavioral health services, at Magellan, we had access to hospital utilization data, outpatient services, tons of, I think we only have one wraparound agency here, so I can say this without the crowd getting upset. Spreadsheets, oh my goodness, the spreadsheets of data that they submitted to us. And we started looking at it and realized that we were missing a group of kids. So where we had, the criteria was set right here, there was this whole group of kids who I think because they weren't probably in the original data set, were coming up as not eligible, but they'd been in the hospital, they'd been in detention, they'd been all these places. So we were able to make refinements with the Department of Health to those criteria to make sure we weren't missing those kids with the highest needs. You went too fast. Thank you. Okay. We also began to get the first kind of system level insights. We were starting to be able, with our electronic cans, to be able to say, kids in this area are doing well in this area or not. Or kids, when I remember juvenile justice person saying, yeah, but how are our kids doing? With all of that data, all of that eligibility information, all the utilization information, and tie that to their cans, we could tell them how their kids were doing, which we could not have done before. And then lastly, outcomes and accountability. I think part of the respect that Karen talks about is accountability. Now, I don't like, having to do my reports on time and have them be accurate and, all of that, but it's important and it makes us better. And so what's been nice about the cans, and I think it's probably made your job a little bit easier, is that we can say, no, this is for real. We can tell you kids are getting better. I can prove to you kids are getting better because their families who live with them, their providers who work with them have all contributed to these answers, excuse me, and they're getting better. Clicker. Thanks. Okay, so this is the fun stuff that I want to talk about. So our real-time kind of recent innovations. Now I want to tell you, not a single one of these items that I'm about to talk about was my idea. I sure wish I could claim them. You know, Karen said I'm a counselor. She's an attorney. Neither one of us are data nerds. We have some data nerds at the table and who don't come out of their offices ever and would never be in a room this big. But those data, well, we do have a counselor who is a data nerd at the table, but I'm not going to point her out, Wendy Bolin. But it's been really nice because having that insight of looking at the data, using our electronic cans instead of those old paper sheets, have really helped us learn some neat things about kids in Louisiana and do some fun things with them. So real time. So we've just all been through, hopefully it's over with now, COVID. In Louisiana in 2020, we had more hurricanes than we've ever had. I live in the very northwest part of the state. Like I'm honorary Texas and Arkansas, way up there. Even I had a Category 1 hurricane in my house. It was terrible. And so we were able to see, Wendy, exactly how the pandemic and how the hurricane were impacting Louisiana families very specifically. We could do it by region. We could do it by level of impact of the storms or the pandemic. We used all kinds of, I don't understand all the data, but there was a lot of numbers and a lot of me trying to remember college statistics. But we were able to see that and tell people, here's exactly what's happening with kids and families in Louisiana right now. So what researchers are going to find in 5 years or 10 years or whatever, I bet you they're going to come back and say, look, they knew way back then exactly what happened. But because we have a huge data set, we have cans on more than 20,000 kids. And if you think they have multiple cans, we have at least, I'm going to make up a number, but I'm doing the math. No fewer than probably 150,000 cans that are in our data that we can look at. So we know what's happening with kids right now in Louisiana. We've used it recently to help identify needs that kids have had that may have been missed along the way. So we can see when we look at services kids use or the kind of troubles they're having that are not on some psychosocial assessment that a therapist did with them before. They might not even have one. They're not, all they come in is saying, Johnny's bad and he getting put out of school. Well, we go into the cans and we get some fun, oh, wait a minute, Johnny's got moderate levels of physical aggression and he's been exposed to trauma. And oh look, and now we see he's 3 grade levels behind in school. Could those be connected? We don't know. But now we do. We can match the clusters of cans items, excuse me, my goodness, with what we see happening with kids and families. And I hope this is not somebody's water because I'm going to get their germs or they're going to get mine. We'll see. Okay, this is a germy water for the next person. So, as a result of finding who those kids are, we were able to partner with these lovely people from the Department of Office of Behavioral Health, with our wraparound agencies, with providers, to put together kind of some guides. If you see these items on the cans trigger, then here are some tracks you might want to follow. So now, a bachelor's prepared 24-year-old wraparound facilitator, or this is her first professional job, has a child in front of them that's 3 grade levels behind in school and was recently in the hospital with some psychosis. What in the world? They're not clinicians. They're not supposed to be clinicians. But they've got this guide to get them started to inform their team of the best way to help take care of kids. Now, we still do everything that we show with wraparound. We follow all the system of care values, family voice and choice, data informed, all of them. But it gives those teams a starting place that they may not have had before. And we're seeing it make a difference in kids going to the hospital, kids having to go to residential treatment or other out-of-home placements. It makes a difference. And then lastly, we're working on integration into other statewide initiatives. So the state has done a remarkable job bringing evidence-based practices into the state. You know, my whole career has been in Louisiana. My whole career was out in the world, serving kids and families. And, you know, I was never the one to sit in the office and have somebody come to me and tell me about, you know, how sad your day was and I'm going to make notes here to write me a big fat check. That was not me. I was always in the Medicaid space. And, you know, there's a lot of services out there, but not a lot of services backed up by evidence. So in the last several years, was it 4 years maybe?
About 4 years.
Yeah, the Center for Evidence to Practice, they put that together and found some really great practices. They've provided training for providers. They provided kind of these little roadmaps for if this is happening with your child, this is a service you might want to consider. And so we've been able to line up our practices with those to funnel kids toward those services whenever possible. Also, this is one close to my heart, a couple years ago, several laws passed to require schools to administer the ACEs before any child could be suspended or expelled from school. Radical change. Radical change. And so it was great because we had recently added the ACEs to our assessment that accompanied the CANs. And so we're able to pull these initiatives that other folks are doing, use our CANs data to use those effectively and to funnel kids to the right kind of treatment, the right kind of services, the right kind of interventions that they and their family need and are able to choose on their own with good data. All right, outcomes. So I'll talk outcomes and we'll both do lessons learned. How about that? Okay, one more click. So if you were in the poster session last night, you may have seen me bragging and doing my Vanna White for one of our posters to look at outcomes. So these are just some 2021 outcomes that we were able to see. So 72%, but on your game it was 71.7% with the percent sign. Don't forget that. For those of you who are playing the game, 72% of kids in CSOC demonstrated a CANS global score improvement of 5 or more points from admission to discharge. Our most significant improvements were in life functioning, child strengths and needs, and child behavioral and emotional needs. And we're really proud of this. There's virtually no difference in clinical outcomes among kids of different races. We don't see that everywhere, and we're really proud of that. I could go on and on about outcomes. The document that we drew this from is 150 pages long, also written by several of the smart people at the table. But there's a poster in there. But I want to say, somebody asked me last night, these are COVID outcomes? Yes, these are COVID outcomes. I think one of the reasons we continue to have such good outcomes, one, we've been at this for a really long time. We have good partners across systems who push us and ask us hard questions that we try to. Is my microphone messing up? Oh, no, you're good. Okay. I was like, I don't think it's messing up. I hear myself. But we have those great partnerships, and they push us. You can't go into a governance board meeting and say, I'm sorry, things aren't working out now because everybody's sick. You can't do that. We're all responsible for taking care of kids. And so throughout these difficult last few years, we've been able to continue the work, lots of support for telehealth, lots of support for doing things in new and different ways, and it really has made a difference and helped our kids get better. Okay, we'll tag team this one if you can click it and that. Okay, some lessons that we learned. Maximize the number of people certified. So if you're going to work in a system, I joke that we throw out those codes to access the online training like Mardi Gras beads. I mean, everybody, if you want the code, I'll give it to you. It only cost me $12. I'll give you the code. I'm making that number up, I don't know. But we want people to be trained, especially in the early days of this system. Gosh, we trained DCFS workers and OJJ officers and DOE, everybody at OBH, everybody at Magellan, so much CANS training. Now, would we like more people to speak the language of the CANS? Absolutely we would. But even people who don't necessarily speak the language, they know the language exists now. We even hear about it. I was visiting with a judge a couple months ago, and even he'd heard of the CAN. Again, another lawyer. But he knew. He knew exactly what it was. And the more people who can speak that language, I think the more people are supportive towards families, and the more people are less blaming and judging, and can really just talk about here's what's happening with our families. Speak cans, I led right into that. Everybody can speak it. Did you want to say anything about the people?
Well, I want to say, as far as train people you don't think will ever actually use the cans. Yes. She mentioned OBH. Back in the day, we had a ton of people in our office trained. They weren't conducting the cans. There were people like me, who did some pretty basic trainings, but it allowed us to spread the message of the cans. And no, I know that provider's really great. I know he's your brother-in-law's neighbor's best friend. But listen, I have some data that I can talk about. Let me tell you the cans. Let me tell you why it's solid. And I'm able to carry that message. Our team's able to carry the message. So, spread it far and wide with who has a working understanding of the cans.
That's a great point. This is what we said at the beginning. Invest in data and analytics. Like I said, when we first started, it was paper cans. My God, the paper, the faxes. My highlighter, scoring cans. But when we moved to an electronic cans, and it's been many years now, but it's nice because it took us from this individual kind of kid information that I could get from looking at a series of cans to being able to cross-well back to all the other data that we have. Invest in data nerds when you can. It's really important. I think about one of our analysts, he's not, I think he was, was a math major, he was something like that. And he would ask questions that I would never think to ask. He would see patterns and go, that doesn't look right. And it could be, it doesn't look right because kids are having trouble. It could not look right because we're having trouble with a particular assessor who's administering the cans. He could see things that I couldn't see. So anything you can do to invest in good data, good analytics, it's totally worth every dollar and minute you can put into it.
Yeah, I'll even add, find your data analytics people and then train them in behavioral health.
Yes.
Because it's harder, I think, to find the reverse. And I'm constantly surprised at our data group for cans and other things, but they have started to speak behavioral health and they'll start to talk about it and the insight they give into that data is really, really amazing.
Mm-hmm. It is. That's a great point. It's a whole lot harder to teach a counselor like me to understand data than it is the other way around. And always go back to the basics. I was in a session yesterday and I think I heard drift about 15 times. And it's true, it's very easy to have drift. It's very easy to not pass the first test if you don't look at the manual and you drift. That's a very easy way to not pass the test the first time. But constantly working on that and going back to basics and reminding folks, we actually have a session on it, is it today or tomorrow, with one of our assessors, that exact reason, to talk about good practice, good assessments, and making sure that we always go back to the definitions. That's always what I say. I know you think that's probably worth it too. What does the definition say? And then engage in collaborative learning. We had a poster in there. I think we've learned together, definitely. We've asked questions together. Those assessors who work with our team at Magellan and the OBH team, and especially the work that OBH does with our wraparound coaches, it gives everyone working at this, on the same problem or the same initiative at the same time, and you really get some synergies of things moving forward. And then stay curious. I know we're talking about data people, but so many things that we've figured out and we've done have come from somebody asking a question. Somebody in the governance board, somebody, a provider, one of us, or somebody sitting at their kitchen table and going, oh my gosh, I wonder if that's what happened. And then the next day they go to work and try to figure out if that's what's happened. But really keeping the cans fresh and using it as, it's a great tool to be, to know what's happening with kids and families. You all know that. But it's that next level of how does that inform our work that I think is really important. And I think that, you would add anything to that?
I'm going to add to that.
Yeah.
So your first iteration of the cans and the process around it is only your first iteration.
Yes.
I think we developed this. We were so excited 10 years ago to have this. We hadn't had anything like this. It could standardize. It could give me data to report when I speak. I mean, this is the 4th time I've spoken this week to a large crowd, and the ability to have those stats and that data that I have a confidence in. But then don't be scared to change. And I look at Wendy, who's been one of the kind of change makers around that. Make it electronic, and then second guess your eligibility criteria, and then do this. So adopt it, get comfortable, sit in it, and then make it better. I think.
Yeah, definitely. So I think that's the end of ours, but we do have a few minutes in case anyone has questions. You have the microphone? Okay, great. So we're glad to answer just about anything. Just about. If we don't want to answer it, I'll tell you. It's very important what you have to say. Everybody needs to hear it.
Okay, are you all listening? We represent New Hampshire. We are in the phase of not only building the plane while we fly it, making it up as we go. We are struggling with our developmental delayed population and where they can access services, not necessarily through our juvenile justice, child protection, or behavioral health realms, and wondering how you all may or may not have partnered with that population for services.
I'll start and then I'll
Okay, good.
Okay, so I mean, who isn't having that same problem? I think it's pretty universal. The benefit that I have, so our Department of Health has our Office of Citizens with Developmental Disabilities, the Office of Behavioral Health, Medicaid, Aging, and then other people. Communications and legal and stuff like that. And so we're all in the same building, and so I'm at an advantage that my peer, the head of DD, we talk daily, we see each other, and so we do a lot of hey, I need your help. Hey, we need to work this out. Let's get on the phone. We had a case all day yesterday and the day before. Our medical director, so my medical director is extremely close to the DD clinical director who knows Magellan and our 5 MCOs medical directors. And it's a lot of collaboration, but I think that's the only answer we've come up with. Let's get in a room and talk. There was this huge email exchange the past couple of days, and it was finally like someone said, we've got to talk about it. And so that happens on the regular. We have a DD system. It skirts in managed care. I mean, it skirts in Medicaid. It has some Medicaid providers, but they're not in managed care. So it's kind of some siloed systems, but luckily my medical director came from Medicaid, and so there's a lot of crossover of knowledge. When it comes to Magellan and CSOC enrollees, not just the Medicaid, Syralja, do you have something to add?
I do. So early on, again, we're going to go to Medicaid world. So we have these 1915C waivers for developmental disabilities, and this is a 1915C waiver. People can't be in 2 1915C waivers. Thankfully, within CSOC, we also have a 1915B3 waiver. But early on, kids could not be in that developmental disability waiver and this waiver at the same time. Forget B3 or C, it didn't matter. We were able to, again, thanks to Candace and some other folks at the state, who were able to make it where kids can be in both waivers at the same time, so you don't have to silo them. They can get both, treatment and services from both systems. That doesn't mean it's easy by any means, but the collaboration that Karen was talking about makes all the difference. Our medical director's here, y'all. We have a doctor in the building. She's a great psychiatrist, and we're really glad to have her, but she and the clinical director at the Developmental Disability Department I think they spent 3 hours together yesterday. But like she said, it is, you have to collaborate system-wide, make changes where people have access to services, and then on individual people. There's still a long way to go to make services friendly from both directions. I mean, and by friendly, I don't mean not getting along, but really where you've got the right kinds of services that can handle both sets of needs. But it is not easy, and
I want to repeat, because you had the right answer. It was very technical, which is if you're talking about Medicaid eligibility, look at your waivers. Mm-hmm. I mean, again, we had to change. Like she said, I want to repeat, at first you couldn't be in a DD waiver, and in CSOC, there was some evolution there. And so get your waiver people to figure out how to make that work.
And then train people, because I don't know about y'all, but when I was in school, and I learned to be a counselor, I learned very little about substance use. I learned very little about developmental disabilities. And all of our worlds are usually very siloed. And so having those people who are in those serving systems learn makes all the difference too.
Very simple question.
Sure.
How many items on the cans did you guys start with, and how many do you have now?
Oh, don't get me lying, Wendy. The whole bubble sheet, that's all I can tell you. Can we give that as a takeaway? I don't remember. So 52 in the core cans, and then we use the modules. Wendy, they can't hear you.
We had one other question over here,
Okay, one more question.
since that was quick.
So Wendy's doing a session. So with
Yeah,
her
right now.
session, you can ask her directly.
If you see Wendy Bowling, go to
I
her
think it's
session.
tomorrow. Yeah.
Yeah. Yes.
When you had the advice to train as many of your partners as you could with the cans, I was wondering if you could talk about what that training was that you provided to all of those partners that might not be administering, but you wanted to have the knowledge.
It's the same it's the online training that the lovely, talented Dr. Lyons does. And we look at his face for all those hours. It's the same training. Everybody's trained the same. And like Karen said, I've never administered a CANS because I came straight into into Magellan right as this managed care system was starting. CANS didn't exist in Louisiana. So I learned it to be a care manager at Magellan. So we all take the same training, everybody.
I will go a step further though. I think we can use training in the, you mentioned speak cans. So we would just put together some basic PowerPoint. So we do a lot of work with judges, all of us, a lot, heavy judicial engagement. So for people like them, a 30-minute PowerPoint on this is what the CANS is and what it means. This is what it measures. These are some outcomes. These are some data points to ask. When you tell me he's not doing well in school and I come back and say, look, suspensions are down, this is why and how I'm able to say it and why I'm right, and I know you're a judge, but you're not. I think that training can just be an introduction, a familiarity. It's deeper than what CAN stands for, but it's not kind of that clinical how you administer it.
Right.
Things like, I think it's important to know that you're assessed at different frequencies, because to the lay person, then they realize, oh, you really can kind of track over time the improvement, unlike a lot of our other behavioral health services. So I would say different levels of training that might not be official. You're not going to get a CEU from it, but talk about it in as much as you can. And sometimes that's hard. It's hard to dumb it down to a non-clinician, to someone who's not like in it, doing it. But it's still important to find that balance of education that's not so far above their heads they kind of glaze over, but enough to where they can understand it and speak. And we get judges talking about the CANS, referencing it, mentioning it, asking about it on occasion. So that's what I would suggest.
Okay, all right, think we're done. Thank you all for letting us talk with you. We appreciate it.